Can you hear me?
I can, Senator Kinski.
Super. Did you have a good lunch?
Yeah, it was good.
That's always a good thing to be able to say.
It is a good
Upright and taking nutrition.
Yep, that's right.
And Mr. Chairman, we are live on YouTube, just for your information.
Thank you very much. Let's see if we got everybody here. Looks like it.
I better get into uniform here then.
So I think we'll go ahead and get started here again. Stefan, why don't we, if you would like, maybe before we go into the question period, if you've got any closing comments on gatekeeping that you'd like to share with us from the Department of Health's point of view, and then we'll go ahead and start taking questions.
Thank you, Mr. Chairman and members of the committee. Just a few, excuse me, a few concluding remarks dovetailing off of our gatekeeping conversation. As I mentioned, that program and that statutory mechanism is really, specific to the Title 25 population and an attempt to make that system work more efficiently and more effectively for those patients. But it's really a good example of the continuum of care that I talked about before, where you have community programs on one end, higher levels of care like the hospital or the Life Resource Center or others. And then on the back end of that, again, your community programs for aftercare and for maintenance in the community. And again, I just lay that out conceptually. A lot of nuance, both legally and financially with that. But I wanted to take just a minute or two, Mr. Chairman, if I may, and talk about the state hospital and Title 25, especially as it relates to the concept of gatekeeping and really this continuum of care that I think we've all been trying to improve for many years, especially since I've been with the department since 2013. But I have had over the past year the opportunity, since our former behavioral health division senior administrator retired, Chris Newman, I've had the opportunity to supervise and oversee both the state hospital and the Life Resource Center for the past year. And I just wanted to update this committee on one element of that continuum of behavioral health care at the state hospital, some positive trends and some positive news we've seen there, and then connected a little bit to this conversation as it relates to where the state could potentially go next as it relates to improving the behavioral health system in the state. Over the last year, as you all know, we've been doing quite an intense construction project at the state hospital in Evanston. The legislature a number of years ago appropriated nearly $200 million for the state hospital and the Life Resource Center projects to not only rebuild those facilities, but as I mentioned before, to remission them and put that in statute to give them kind of a one facility long streets mission and really define that role of the state so that we can get back to the core services at the state hospital of acute stabilization, and then also set up the Life Resource Center for a longer term sustainable future. In this past year, the state hospital is nearing substantial completion in the construction project and thanks in no small part to Representative Larson and Representative Nicholas' good work on the task force and the work group that's been helping us manage those construction projects. But in the last year, like I mentioned, we're nearing substantial completion at the state hospital. In fact, we're gearing up by July 6th to start moving in staff and patients to the new facility. And so between July and September, we will be moving into that new facility, increasing capacity for our communities and our counties in both Title 25 and Title 7. And it's just a very exciting time, even given the troubles and uncertainty that we're going to face as a state when it comes to budget and revenues. It's an exciting time for the department and for that facility, and frankly for this population. About a little less than a year following, we should be opening the new Life Resource Center, which will have the intermediate care facility and a skilled nursing component to treat a variety of populations that have been defined, but also to alleviate some of the pressure on the state hospital by caring for the long-term care population that currently resides at the state hospital and basically occupies short-term beds. So this is, again, one part, but a very important and critical part of the behavioral health continuum that it's worth this committee, knowing and getting an update that we still have our eye on the prize there. And like I said, it's very exciting to be nearing completion of one of these projects. But I also wanted to mention that in the past year or so, some of the metrics at the state hospital have really shown promise to, again, help us shore up and improve this continuum of behavioral health for some of our most acute and clients most in need. Our Title 25 cost, as I mentioned earlier this morning, back in the 2015, 2016 kind of era, we were approaching and actually did approach $19 million of biennial Title 25 costs with a $4.4 million budget. In the past 2 biennia, we have cut those costs in half. The legislature has been kind enough to give us access to some LISRA funds, as well as an exception request for an appropriation. But going from $19 million on a biennium to what we're trending right now is just over 9 in Title 25 expenditures is a testament to some of the work that's been done, not only at the hospital, but also in our communities, and especially in our Medicaid program, who really took on the claims processing and the data system and kind of handling our policies and our procedures when it comes to claims from private and designated hospitals in Title 25. So a good financial trend there of reduced expenditures in Title 25 is certainly a good sign. On the operational side of the state hospital, Mr. Chairman, I wanted to mention, because it is the first time since I've been with the department that I've seen this. We had a lot of concerns from the Facilities Task Force, the Labor Health Committee, and other stakeholders that we would struggle and might not be able to staff the new facility with an increased bed capacity. And that's certainly a concern going forward to staff a psychiatric hospital in Evanston, Wyoming. We constantly struggle with staffing, not the least of which reasons is because of the location, but also because psychiatric hospitals are difficult places, but rewarding places to work. For our nurses, it's the first time I've seen since I've been here. We about two and a half months ago, we were full on nurses. Right now, I think we have 2 nurse vacancies. And so we've been really pushing on staffing that facility with, not having to rely as much on contractors, which charge a premium. And the recruiting has been really good, both with our nurses and our CNAs trending in a positive direction since last summer. In addition, our turnover rates for nurses and CNAs have been on a relatively steep downward trend, which is really good to hear. And I think a lot of that is due to the great leadership that we have at the state hospital and folks being motivated with their mission, with the allure of moving into the new facility later this year, having a better place to work, a better physical plant, and achieving some better outcomes for those patients. So both on the vacancy side and the turnover side at the state hospital, just wanted to give the committee an update that we are still moving in a very positive direction, and again, optimistic and excited about what the legislature has helped us do with those 2 facilities. And that brings me to my last comment, Mr. Chairman, on the continuum. Like I mentioned, State Hospital and Life Resource Center are one part of that. And I think the progress that we're showing on the facility side, both with physical plant and construction and recruitment and retention and general outcomes, length of stay, wait list, things that are moving in a good direction. It just, again, makes me optimistic that I think that some of the tasks a committee like this is taking on when it comes to improving the other ends of that continuum with our community programs, with really doing the work to define what a safety net means, what the services that need to be provided for these different types of populations. I think we can really make progress. So just wanted to give the committee an update. If you talk to our state hospital administrator, Bill Ryan, who's a fantastic leader, over 40 years experience in this field, we've had a lot of conversations over the past year of how crucial this component that we're discussing here, how crucial this is to even the mission of a psychiatric hospital like the Wyoming State Hospital, both on the front end and the back end. the success that I think everyone here envisions for the continuum of care with a tough policy area like behavioral health relies so heavily on our ability to align our communities with not only the mission, but the operations and the procedures of the state hospital. So I commend this group for dedicating your time to help us solve some of these tough problems and hopefully make some progress and move in the right direction. So, Mr. Chairman, that's a little digression from gatekeeping, but gatekeeping is a small component of this general concept that I'm talking about with the continuum. So happy to stand for any questions. And again, appreciate the committee's time this morning.
Committee questions regarding Mr. Johansson's presentation on gatekeeping? So Stefan, I have a couple that I want to make sure as I listen to Andy and Paul's comments earlier and then your presentation. It sounds like in what I've run into is we do have inconsistency across the state on how the gatekeeping process is administered. And so to that end, I then hear you say that in 2020, you'll be incorporating that into the gatekeeper services contract with each community mental health center. So my first question is what if a community mental health center doesn't want to be a gatekeeper in that process? Is that okay?
Mr. Chairman, I think, yes, it would be both okay and not okay. I think the statute gives the department permission, it's may language, not shall language, to designate Title 25 gatekeepers. So we take the approach of, like I mentioned this morning, working with county commissions and working with our mental health centers or other interested providers to designate who can take on that work. When it comes to what will be in the general behavioral health division contracts for gatekeeping, like I mentioned, there will be some standardization. We'll cross that bridge, and I'm happy to let our behavioral health division staff speak to this of what's coming in the next month. But I think I would be surprised if we didn't have a receptive attitude towards providing those services and being able to include them in their data reporting and reimbursements under the contract. But like I mentioned, it is a mixed bag in what certain communities need in terms of gatekeeping and services for Title 25 clients, largely due to population, resources that are available in the community. So it kind of requires, quite frankly, Mr. Chairman, when you talk about Title 25 gatekeeping, we have resources located in many different parts of the state and in many different parts of the community mental health and substance abuse system. And a good example is a gatekeeper could, in fact, in your neck of the woods in Fremont County, be dealing with a Title 25 or potential Title 25 case and identify that this particular individual could benefit from a group home, for example, as an alternative to hospitalization. But there's no group home beds available in Fremont County. Where I think we have some room for improvement is more coordination across the entire statewide system to find where the resources are. And to your point, kind of unify that approach of coordination of where those patients could best benefit from resources that might not be located locally within that, for lack of a better term, that gatekeeper's jurisdiction, if that makes sense. But if our behavioral health division is on, I'm not sure if they are, happy to let them speak to gatekeeping elements that will be included in the contracts, or we're happy to follow up with that information too, as those contracts get developed this month.
So I kind of asked that question of our two WAMSAC folks, and they said that coordination on it was going very smoothly. And so at least that's what I heard. And so then let me ask, will you define then in the gatekeeping contract the responsibility of that's unique to each of those communities? Will that be identified by the Department of Health and the county as they issue that contract, or and will there be a need for some fundamental consistency across the state, and will any of that, in your opinion, require legislation, or do you think you can do it all by rule?
Thank you, Mr. Chairman. Just really briefly, and I'll hand it over to Matt Petrie and Ben Kiefer in our Behavioral Health Division. But very briefly, I want to mention that I don't think in the short term that legislation around gatekeeping would be necessary. I think we have again the authority that's needed in statute to define what those services and standardize some of what those services might look like. We are in the middle of contract season right now in prep for the July 1st start of the new biennium. So I want to let our Behavioral Health Division, who's more in the details there, speak to those contract elements. So Matt or Ben, are you with us?
Yes, Stephen, we're here.
So Matt or Ben, I don't know who's going to talk here.
Good morning, sir. My name is Ben Kiefer. I'm the Mental Health and Substance Abuse Administrator for the Department of Health. With regards to your question, sir, with gatekeepers.
Ben, if we could have you raise your hand, because we don't know which one is Ben and which one. There you go. Thank you.
Right. Sorry about that, sir. Can you all hear me?
Yep, we can hear
I'll
you.
get a little closer to the mic.
No, you're fine.
Prior to me coming here, as Stephen described, the gatekeeper services, we had 4 different centers that had gatekeeper contracts. Again, these 4 different centers provided those gatekeeper services to their county and in a regional approach. That was a pilot program that we consolidated into a service, an actual service definition that we call emergency diversionary bundled service. And essentially what this does is it spreads those services to all centers in the form of an RVU, which they can then deliver gatekeeper services or emergency services defined by the service definition, and then be reimbursed at a higher RVU rate, which incentivizes, again, that diversion.
Help us understand what RV or RDU is.
So RVU is how they are paid by their service hour. It's a relative value unit. It's associating essentially a cost to a service hour. So again, as Stephen mentioned earlier, the standard amount for general population is $87. With this EDBS, we had hoped to increase that to the priority population level and even beyond that to incentivize those type of services and emergency services, outside of their 4 walls within their community mental health center, to include all the things that are traditional about gatekeeper services, court appearances, case management, again, responding to hospitals and detention centers to provide either assistance or assessments. But a lot of the things that were mentioned previously by the provider there in Carbon County, those emergency services that they were previously not paid for, they will now be able to access that RVU and be reimbursed for those types of gatekeeper and emergency and diversion services.
Thanks, Ben. Mr. Chairman, does that answer your question? And we're happy to provide this committee either virtually or when it convenes again an update on exactly what gets executed with the contracts starting July 1st. But I will mention, and Ben and Matt are living this right now. It's somewhat of an uncertain time. We've been directed to prepare pretty substantial budget reduction packages for the governor, as you all know. So all things contracting, all of our providers, all of our programs are currently on the table and under discussion between my office and the director and our CFO and our division administrators on exactly what those reductions will look like. So there's a few moving pieces, Mr. Chairman, but we're happy to provide this committee with updates as we finalize what those contracts will look like.
Senator Kinski, please. Can't hear you, Dave. Not yet.
The old mute button.
There we are.
The old mute button. Kudos and then a couple of questions. The kudos first in the accolades in terms of reversing the Title 25 expenditures. There may have been a tip of the cap to the Labor and Health Committee. I don't know, but I think it's important to note that. I know Representative Barlow was very active because I was trying to get a handle on it in our own county. And Representative Barlow was on the committee at that time, and a tremendous resource for me in terms of the kind of legislation that was coming down the pike on Title 25. And there were some very imaginative and far-reaching bits of legislation that came out of that I think have likewise impacted that. So Representative Wilson, I think you were on labor health at that time. I don't know about Representative Olson or Larson, but you guys were dragging the chain at a time when it looked like there was just going to be no end in sight to Title 25 expenses. The question I have for Stefan, and it leverages off of a little bit of what Representative Larson was saying, where we heard the center saying from their perspective was going okay. I guess that's a relative term, because I know from here at the local level, the community mental health center can have all sorts of commitment to acting as a gatekeeper, but you've got to have the cooperation of the hospital. You have to have the education and buy-in of the physicians in the emergency room. You have to have the education and buy-in of the county attorney to whom the patient may be transferred. Law enforcement in the case of violent patients, what's their role in terms of affecting that transport? So going well is a relative term. What authority do you have, whether moral or legal, to pull all the players in on the Title 25, Stefan, and make sure that there's buy-in from them while we're paying the mental health centers and cajoling and ordering them to go get involved? Thank you, Mr. Chairman.
So, Stefan, along that line of Senator Kinski's comments, and you and I have had multiple discussions on that, where we see perhaps our designated hospitals full, our state hospital full, and so the rural counties end up, the courts place them in the jurisdiction of a hospital. And so my question then is, we've seen some back and forth over who then's responsibility are they, who makes the assessment, who does that, and what role does the gatekeeper have in that whole process. I'm assuming, maybe this is to Matt, I don't know, maybe you, Stefan, but is that going to be defined to where it kind of takes some of that guesswork out when those circumstances arise, where those responsibilities are clearly delineated?
Mr. Chairman and Senator Kinski, let me try to take those in order. Great questions, by the way. For Senator Kinski's question, I think in terms of our authority, either moral or otherwise, for bringing together all of the players in Title 25, I think it's limited. And there's a balance there between, some local control and kind of community and county law and policy that I think most states, including Wyoming, really put that first 3 to 5 days of jurisdiction in a civil commitment process in the hands of the locality or the county. And that's certainly what we have here. I think, Senator Kinski, in terms of our moral authority, it's a great term, and that's, I think, the authority that we have. We have been, I think, somewhat successful in, for lack of a better term, kind of a naming and shaming tour many years ago on counties or communities that might have been able to do things better by not anything really the department had direct control over, but better communication, better coordination, like you mentioned, with some of the players in the county offices, county attorneys, law enforcement, mental health centers, hospitals, et cetera. But it's certainly not perfect, and that legal authority only goes so far. But I think when we have aligned resources as much as we can to, for lack of a better term, incentivize both providers and communities to come together, pool resources, and treat this population as their own, not a population that needs to go to WBI or needs to go to the state hospital, and that's that. That's where we've really seen success, and I won't directly contest the comments from our friends at WAMSAC earlier today on it's all going smoothly. I think it can always be improved, and like I said earlier, it's a mixed bag of not only resources that are available in various communities, but also different parties within the Title 25 system that work together. As this committee knows, Title 25 has a lot of cooks in the kitchen. It's one of those areas of policy, and not unique to Wyoming, that literally involves almost every part of county and local and state government, between providers, between law enforcement, between legal folks, case managers, mental health providers, et cetera. It just, it's a tough system to standardize and unify. And Senator Kinski, we hear often of proposals or concepts or ideas of, hey, the department should just take over Title 25. And that's certainly an option. We should fund it and that kind of thing. That's an option, but you lose that local control and that tacit knowledge the more you have the state kind of control that process. And then finally, and I'll see if our division has any comments on that, but finally, I would say to Representative Wilson's comments from earlier, I think this really comes down to this missioning of community resources, and in this case in particular, community mental health resources. Title 25 is one component, like I mentioned, of this overall continuum, but the more and more that we prioritize a wider range of populations, then, as Representative Wilson put it very eloquently, you start losing your priority status the more priority populations that you have. And that's a tough conversation. So years ago, you know, I think there was some consternation about the department maybe focusing community resources or policy proposals too much on Title 25, but that's the only problem we needed to solve. And I think there's a delicate balance there. But like Representative Larson was alluding to earlier, we are seeing more and more, especially in this new-ish coverage landscape, not perfect, but more insurance for mental health, more Medicaid for mental health, more providers of mental health. We are seeing in that wider market a more and more concentrated need for harder to treat populations, higher acuity populations across your geriatrics, your high need adolescents, the population that kind of floats between the DFS and the Medicaid space, and really hard to treat, hard to place type of populations, your Title 25 populations, and your corrections populations. And that seems to be more and more, again, kind of anecdotal right now, which is always against my better judgment. But anecdotally, I work on more of those cases in a given week, trying to find resources or trying to work with Medicaid and DFS as a team, with our county attorneys, with our state hospital, with WBI, because we have a specific client that is really slipping through the cracks, and either providers won't take them, the funding source isn't aligned, for a variety of reasons. We just struggle with some of these harder to define and harder to treat populations that are not really your general access type folks. And so again, that's not a slight against any type of provider, community mental health, hospitals, what have you. It is just a resource allocation issue in many cases. So again, going back to my previous comments, I think that's really a targeted problem to solve, either with this committee or otherwise, of, you know, again, what is the role of the state in catching those populations? And it's not thousands. I mean, it's probably hundreds in a given year. This relative handful of clients that really don't fit into a specific definition and really have some high acuities and some comorbidities and some tough challenges that we really just don't have a good system to catch them as a safety net between Department of Health, between DFS. And so I'll stop there. I see Representative Wilson has a question, but she did direct us and DFS on the adolescent side to get together between now and August and kind of map some of this out for some of those really higher acuity kids and adolescents that I think is another good microcosm of this overall problem. So Senator Kinski, Representative Larson, sorry for the long-winded answer.
Sorry, Representative Wilson, please.
Thank you, Mr. Chairman. I have a question here that follows along that somewhat in the discussion about the coordination. And what I want, and I should have probably asked it when Andy Somerville was still on, but do the mental health centers have access to a unified medical service record such that we could, you know, the discussion about they're in the community mental health center, they need a group home, it's out of the county. And so I'm wondering if there's a medical record that they would all access to, and does that link into the health information exchange that I think we've been kind of chipping away at for about a decade or something. In some ways it sounds a little extraneous to our discussion, but like many things, if you can kind of knock down silos and improve coordination, we might actually be able to take care of people better. But Stefan or maybe behavioral health folks, and I think Andy's probably gone off, but.
Oh, she'll be back.
Mr. Chairman, if I may, and Representative Wilson, it's a good question. So the short answer is not really when you're talking about connecting to a wider health information exchange. But like you mentioned, we are working on it. I'm trying to pull it up right now. Our Medicaid division, our healthcare financing division, has done a fantastic job in the last really year and a half to take over what was kind of a flailing statewide health information exchange project and stand it up. So we do have an active health information exchange that we're continuously adding providers to, both hospitals and clinics, even the state facilities. Life Resource Center is coming online as a viewer of that health information exchange data, with the intent of exactly what you're saying, that when you have a client that might have a history with another provider or medical or behavioral history elsewhere, the idea is to have that health information exchange that we could certainly expand to the provider types that you're talking about with mental health and substance abuse. So I'm happy to follow up with that information. I'm trying to pull up the spreadsheet right now on our provider enrollment, but I think last year it was in the less than a couple dozen. I believe we're in the hundreds now in enrollment, but I'll have to follow up on those connections. But a great question, and we're trying to move that forward as quick as possible, with mostly federal funds, by the way.
Okay, Senator Schuler, please.
Thank you, Mr. Chairman. I do have a couple more questions on the gatekeeper issues, but before I do, I feel like I should also add some kudos to Representative Nicholas and Larson. I think this facility that we're getting up here at the State Hospital is turned out to be a really nice facility. Been up there a couple of times, and you guys have done a great job. I think it's going to help with a lot of our issues, having one large campus instead of being spread all over the place, and having single occupancy. And obviously, I think you guys made a good hire with Bill Ryan, and he's done a great job of kind of turning things around. And I would also like to just pat Stefan on the back, because it's been a tough road to hoe over there at times. And you've done a great job being a good liaison, and I appreciate all your work there as well. I just wanted to say that real quick, because I think that's something that's really going to help with our Title 25 and a lot of other issues. But anyway, my questions, if I can remember what they were. With the gatekeeper, I wondered how they, are they on a 1-year or 2-year contract? How are they funded? And basically what happens, because I know you have to have the county commission input after the department chooses one of them, but if you've got one that maybe is serving 3 or 4 counties, like maybe Peak Wellness, how does that work? Could you just maybe give a little more clarification on that? Thank you very much.
Mr. Chairman, Senator Schuler, I'm going to kick that to Matt or Ben to answer briefly about how those contracts work. I believe, Ben, if I'm not mistaken, our current separate gatekeeper contracts expire at the end of this month with the end of the biennium. And like we've been talking about, will be incorporated into that emergency service definition in the broader contracts. But Matt or Ben, you might talk about especially our designated gatekeeper providers that serve multiple counties, exactly what that looks like.
Sure, I can take that one. Mr. Chairman, Senator Schuler. So the answer to that question, for example, with Peak Wellness covering multiple counties, that RVU is portable. So no matter where that service delivery happens, they can still be compensated for that through the reimbursement of that RVU.
Okay. Any other questions? Okay. Oh, Representative Barlow, please. Sorry.
Thank you, Mr. Chairman. So I'll make a couple comments, and then I'll have 2 specific questions for Stefan. And they're going to be a bit leading, because I think I know the answers to them, but I think I want the committee to hear the answers that Stefan will impart on us. So I'm just going to go a little bit back to 2014, 15, 16. There were really three things that the task force, it was a task force, I believe, not a subcommittee, because the governor had appointees on it as well. At the time, Director Forsland was part of it. Robin Sessions Cooley was on it. There was a county attorney, et cetera. So I think it was a task force, but maybe not getting the name correct. But anyway, so there's three things. One was directed outpatient commitment. I believe that was a significant part of those discussions, which is in current statute. Gatekeeper was a considerable part of that discussion. And then a lot of minor changes, adjustments, et cetera. Probably the thing that made the most significant difference to Senator Kinski, Co-Chairman Kinski's point about costs, was what the department did internally within Chart B and Medicaid. I think, and anybody that, I think Stefan's nodding his head, I think anybody that actually followed, the trend lines and the costs and the provision of services says that's where actually costs were improved. I'm not suggesting that the care went up or down. I'm just saying that's where cost containment or cost understanding at least came the most from. Others played a role, but that's probably where it was the most value, which was an executive function, not a legislative function, although we certainly talked about it. So two questions and two changes that came also out of those several bills, but that came out of that discussion and subsequent discussions were, one is the 72 hours, which is a component of statute. That's a legislative choice we've made, that the counties, of course, that 72 hours plus and minus weekends and holidays, or plus weekends and holidays, that the county pays. But one of the things that we've done, we asked, is that county attorneys and subsequently gatekeepers notify the state about when they were having these actions, whether it was an emergency detention, a 109, a 110, any emergency action in this thing. So my first question is, are you getting notifications in the absence of gatekeepers, i.e. from county attorneys, because they are actually making that decision to go forward with an emergency detention or a IH hearing, 110 hearing to the courts? And two, are we paying the gatekeepers for the first 72 hours? In current statute, it's allowable by agreement that the state would take over the gatekeeping costs, if you will, provision of those services for the 72 hours. So two questions. One, are you getting the notifications in a timely manner, which is currently by statute 24 hours from any of those actions? And two, whether this new contract concept is anticipating that we're going to start with gatekeeping service from hour zero. Thank you, Mr. Chairman.
Thank you. Stefan, is that you or?
Yes, Mr. Chairman and Representative Barlow, I'll take your questions in order. And if you'll bear with me real quick, I am going to share my screen because to your question, Representative Barlow, with that statutory requirement, we did create a number of years ago a website for county offices to go to make that notification a little bit easier. So the simple answer to your question is yes, we are getting notifications. I would pull up the spreadsheet, but that would be a major HIPAA violation. No offense to the committee, but you're not entitled to see that information of what we're getting because it does contain patient info. But this is the form essentially that county attorneys can or have their offices fill out when one of those events, an emergency detention, continued detention, directed outpatient commitment, involuntary hospitalization, when that happens, they can go in here and just fill this in, and it feeds a back-end spreadsheet and a dashboard that we have. So we are getting information. I would say it's a mixed bag with the 24-hour compliance, and you and I have talked about this. I've shot my mouth off at other committees who didn't necessarily like my comments that it's not necessarily that we need the data within 24 hours, especially like you mentioned, if we have the community partners involved. If we have a gatekeeper or community mental health center or a provider that is managing that case, coordinating those services, then the information flowing to the department, it's not something that we're turning a siren on or something when we see an emergency detention come through, because that still needs to work its way through the process. But we are getting those notifications. I would just say the variability is, do we get them within 24 hours? Not always, but most counties are pretty good at least sharing that information with us retroactively, sometimes on a monthly basis in a spreadsheet. And you have some turnover in your county attorney offices that you get a new person in there and they didn't know about that requirement. So I'll get a phone call, hey, how do we do this? And I'll send them this form to fill out. To your second question about, and let me just pull this off the screen here. To your second question about if gatekeepers, when they're designated, are paid in that first 72 hours, the answer is yes. And it's somewhat of an indirect yes, because as Ben mentioned, right now, those are separate gatekeeping contracts. And so those, those are contractual obligations, and there's nothing that prevents the gatekeeper from providing those services within that first 72 hours. So that does meet that statutory change that you and I talked about years ago about ensuring that there isn't a fight essentially between counties and the state of who could pay for that. So essentially we are covering those costs when a gatekeeper is designated. And going forward, as Ben mentioned, to have that part of the normal, the larger contracts as the ability to essentially be reimbursed for emergency services, including gatekeeping, that will be consistent with that if we have a designated gatekeeper that's operating in a community, in a county, and it's a community mental health center under these contracts, that first 72-hour designation that's in Title 25 statute, in terms of usually the hospital bills that are needing to be paid, that wouldn't be a barrier in my mind in those contracts. But I'll let Matt or Ben weigh in if they disagree, or just shake their heads no if I'm entirely correct. And Representative Barlow, does that answer your question? Mr. Chairman, if I may, I did want to give Representative Wilson an update. I just pulled up that data on what we call the Wi-Fi, WYFI. It's the statewide HIE project. As of this month, I am showing 71 live contributors, 13 in active implementation, 17 in pending implementation, and about 10 or 20, between 10 and 20 that we're kind of waiting for a response or an initial enrollment. So it's not, I mentioned hundreds, we're approaching, over 100 in terms of active users. But again, I think as you might remember, that early HIE project, it's really a problem of the first mover. So if you can't incentivize providers, which we're trying to do, to join, because there's really no value to them until there's, kind of a critical mass of information that's flowing that will benefit their practice. We're slowly but surely building that. And I'm pleased with the way that's progressing, and we should see more and more providers each month come online. I will touch base with our folks over at Healthcare Financing to see what the plans are, if any, if it's short-term or long-term, when it comes specifically to mental health and substance abuse providers, because the focus initially, I think, has been on hospitals, on rural health centers and federally qualified health centers, as well as patient-centered medical homes and things of that nature. So I'll double check on the behavioral health provider plans and get back to you.
Thank you. So Stefan, I'd like to follow up on Representative Barlow's question. So when there's a commitment process in place, somebody brings somebody to the hospital, as soon as the community mental health center, who may have that gatekeeping responsibility, becomes involved, then they can be compensated for those efforts, because they have to go up and do the evaluation to determine if it's worthy of commitment and those sorts of things. Is that not correct?
Mr. Chairman, that's 100% correct. And I think just really quickly, as much as we can put into law and rule and policy and contract of, here's how that works, it really comes down to awareness at the community level of who is doing what job. And I think that's something we can all in the department and with our providers and with our communities improve on, and not to not to completely dime out the center part of the state, Mr. Chairman, that you come from, but I think at the community level, if the hospital has a good communication and working relationship with the county attorney and the mental health center and law enforcement, that's when you really start to see things coalesce around a problem like this. But often, unfortunately, we deal with a lot of communication breakdown because of how many players there are. So I think the more that we can use the department's contracts, the department's policies to make sure that folks in a system like Title 25 or involuntary commitment are aware of who's doing what job and responsible for what job, then that's where we really see progress. That it doesn't matter if the department has a requirement that someone notify us within 24 hours because it's a knee-jerk response for the hospital to say, oh, we got law enforcement brought us a potential emergency detention. We're calling the community mental health center. That's the first call. And a lot of the time, that's exactly how it works, because a lot of our mental health centers do those evaluations and are the point person for it. But then when it comes to kind of the back end of that commitment process, when it's time to identify resources or think creatively about alternatives to hospitalization, or what Representative Barlow and I have seen over the past several years with communities experimenting with directed outpatient commitment, which I think everybody would like to see more of. That's where I think we have some room for improvement, both with our policies and our rules and our regs, but also, again, going back to this mission and this role of the state conversation. If there are a subset of populations we're trying to catch, including Title 25 and including higher acuity folks, then consolidating that, refining that, and directly missioning that can only further that goal of that sort of community cohesiveness, so to speak.
Okay, thank you. Committee, work group. Any other?
Mr. Chairman.
Barlow, please.
Thank you, Mr. Chairman. I think you said Eric Barlow or Representative Barlow. So I just want to point out and to the directed outpatient commitment and some of these discussions, and as we've gone through this process many times over several years, the courts are, of course, a big part of this. And so let's not overlook the fact that our court system, who have to deal with the making the decisions, if you will, for a 110 or 110.1, et cetera, and continuation of a plan after 6 months, et cetera, or hospitalization, which is a 110. The court also has to be a part of this discussion, and we've had good discussions with Judge Christensen and Judge Fenn and others over the past years. But if we're going to, as we start to think about other ways to do this, and whether it's not the funding side's important, but we also are the ones that laid out. For your danger to self, others, or inability to care for yourself, then we laid this out. This is our system. So we can make it as inefficient and ineffective as we choose to, or as efficient and effective as we choose to. So I don't know where this goes with Title 25 per se, but I don't want to overlook the fact that the legislative branch laid it out, the executive branch executes it, but we rely on the courts to actually implement, to actually make those tough decisions in this process. So that's just more of a broad comment, but thank you, Mr. Chairman. Thank you.
Thank you. Okay. Well, with that in mind, I think we probably have Mr. Dimple back up. I think we're ready to go to public comment. Unless there's part of Stefan, do you have some remarks there?
No, sorry, Mr. Chairman. I was just waving goodbye before I turned off my video.
Yeah, don't go too far. Thank you. So Elizabeth, if we can let Paul and Andy and we'll kind of get ready for Mrs. Folan as well. And Paul, are you up? I'll unmute you there. There you go.
Thank you. I'm just going to be super quick. And I just want to show you guys 3 different slides and then talk about how the title, or not Title 25, how the gatekeeping process is working in our 4 counties and how it's not working. And I apologize to the committee if I'm not quite sure what I said, but if I gave the opinion or it came across that gatekeeping was working fine. Because that's not necessarily the case, but it's more complicated than that. So what I'm going to do is I'm going to real quick, I'm just going to share this, show you 3 things, then I'll come back. Okay, so you should be able to see a slide that says number and percentage of individuals. So this was in a document that I had sent you, shared with you, that we'd actually sent the Behavioral Health Division on an update on the gatekeeping. This is for FY19 and the numbers of what happened that and how did people get diverted or not diverted. And you'll see that at the ultimate, 13 people were directed outpatient committed. I'll talk about that. 59, or the majority, are actually just released for various reasons. 45 were sent to a designated hospital, primarily Casper. Another psychiatric hospital, I'm not quite sure where that was at. And then 4 sent directly to the Wyoming State Hospital, which is very rare. And we actually had one that the state hospital was great here recently in the last 2 weeks, where they took them directly for various reasons. The next one is enrollment status. And why this is important, it says who's involved with community mental health center, who's not. Out of the 126, only 27, let me scroll that down a little bit, only 27 were a current client of the mental health center. And this is just Northern's data. 99 of the 126 weren't clients of ours. And so what we know is if people get involved with us, they're less likely to be in that system. For some of these folks, this was their first entry into our system. Then the last slide I'll show is, so how many ER visits after the first gatekeeper comment or contact? Of the people that were clients, out of the 27, after we had that first gatekeeper contact, only 2 ended up back in the ER during the measuring time. If out of the 99 that weren't our current clients, but we took them on in terms of gatekeeping, only 9 ended up back in the ER. So with that, I'm going to stop sharing, and I'm going to give an overview, or just a quick. I was excited about the gatekeeping additions to the statutes. One of the pieces we put in there that's not been mentioned was when we tried to do previous convalescent leave, there was a problem that people had to come back under Title 25, even though they're under convalescent leave, in order to get back in the system. So what was added, I think, is a measure to deal with that was the ex parte part of the Title 25 statute, which allowed a judge, without the client being there, to say, you know, if we went and reported back they're not on their medications, they're not dangerous yet, but we're heading there, for them to say, on the directed outpatient commitment, we're going to revoke it, we're bringing them back in. The last report I had up in our area was, I think there was 5 or 6 ex parte orders given to a judge from this one county attorney. None of them the judge signed, for legal reasons, for what reasons, I don't know. So that piece, for whatever reason, is not, that mechanism isn't working to get people back in the system before they end up very dangerous to themselves or others. The other thing that's really important here is, and quite frankly, I hate the word gatekeeping, because gatekeeping means I have control, and we have no control over this. We can comment, we can give opinions, we can do a lot of things, but the one thing, and I think it was mentioned here, that what happens is a doctor will do the Title 25, then they call the mental health center gatekeeper to say, is it, you know, do we approve? That never happens, because there's no authority for them to do anything. There's no authority for us to intervene. There's no authority for us to gatekeep and tell who's in, who's out. And it creates some issues. And what it actually does is there's one specific case, and I have a large number of these, that because and I'm designated as gatekeeper in all 4 counties, and we've set up all kinds of different things to do this. The typical case how it really happens is somebody gets under Title 25 and in a very small county, and they end up maybe at the local health facility or in jail. They try to get them to a designated hospital. That doesn't happen. So then the county attorney calls me and says, call the designated hospital and tell them they have to take them. And we explain we can't do that. And usually we do a lot of work trying to make the phone calls and say, can you really do that? But the idea of a gatekeeper, as it's written in statute right now, we have no authority. And what it really did was, which is great, before these hearings would be kind of, we wouldn't be involved with, and we wouldn't know till after the 109, say. Now we're notified right away. And so we can start giving opinions. We can start saying we can do this, that, and the other, which we're doing. So in terms of the idea of gatekeeper, there really is no gatekeeping process going on from my standpoint, because I have no authority. But we have made an impact to get people better services, get them in. It has got us in the system better, quicker. So that's kind of my diatribe on the gatekeeping. I think there's a lot of work to do, but at the end of the day, it's a legal system. And that's where it kind of begins and ends, regardless of the amount of input that we're going to have. So with that, I'll stand for questions.
Any questions for Mr. Dimple? So Paul, I've got a couple. My first one is I'm interested on your use of the directed outpatient commitment, because there's seems to be some coordination between the gatekeeping component of that with an understanding from the county attorney and the judge that that's even a possibility. And I would be interested, because you serve a number of counties, your success in getting that done and how you've managed to do that, or if you feel like there's still, maybe it's not been successful.
Mr. Chairman, what I'll tell you is, quite frankly, those are all in Sheridan County. And I think we may have one in it actually started here and ended up in another, but primarily Sheridan County. And the reason we have been successful is we were excited when all this came down. So we met with the judge, the county attorney, the representative attorney, and said this could be a really good way for people not to have to go to the hospital. And so it was a buy-in. Mostly at the end of the day, the judge won't consider it unless the county attorney, and I don't know what the legal terms are, the county attorney has to present it as a option, and then the judge will say yay or nay. So I think it's been successful. There's a lot that the other parties may not see of all the work we do and where people could end up back in the system. But at the end of the day, the reason it works here is because we had players that said, let's give it a try. If I would have had just one of those players, especially the county attorney or the judge, say I'm not interested, you wouldn't see any numbers.
Okay. So then I'd like to follow. Thank you. That's very helpful, because it's been a challenge in my part of the world and it seems like a very reasonable approach to diversion. Help me understand. You said that you sent 45 to designated hospital and 4 went to the state hospital, and I'm trying to understand that rationale. Was that because the state hospital was full, or do you use the designated hospital first?
Well, years ago, we used to be able to send people directly to state hospital. those days are over. And in fact, it's only been more recent, probably the last year, maybe with the new superintendent down at the state hospital, that they've been very open for us to call them and say, we got one that, you know, we got to, and to help us out as they're triaging. Where do people go? It's really based on bed, and the people that primarily have the beds is a designated hospital. And that's probably the long and short of it.
Well, and I understand that, and Stephan, I understand just, you know, how all of this works. I was just wondering though, in your process of doing that, did you just bypass calling the state hospital first and just automatically go to the designated hospital, or is that just the end result?
When they're going to the designated hospital?
Yeah.
It's just the opposite. What happens is, because of the way the utilization has been, there's no beds at the state hospital for the volume. So the primary cutoff, they'll be on the list, but the state hospital has priorities too. And so they have a list of people at the designated hospitals coming. So in reality, the way it works is the opposite, where the primary people that would take it, we don't really select. We'll take whatever bed's available, but they're primarily available there with communications with the state hospital. The ones that ended up directly to the state hospital were some super high-end cases where they're very difficult. I mean, everybody agrees there's no path, you know, they're coming there, and the state hospital have been good about moving it. So we don't decide who we're going to pick. It's more, here's the system, where's a bed?
So Stephan, can you help me with that a little bit? Because what I'm hearing Mr. Dimple say is that they bypass calling the state hospital and they just go where they know there's beds.
So, Mr. Chairman, I don't disagree with anything Paul said. I'll speak from the legal and the department side of how this works. So just for the committee's edification, the reason that folks go to, let me back up. The vast majority, probably 99% of actual involuntary hospitalization orders commit a patient to the Wyoming State Hospital, to the custody of the Wyoming State Hospital. The primary reason why designated hospitals like WBI, Cheyenne Regional, Ivinson in Laramie has a few beds, I believe Campbell County has a few beds, psychiatric beds, I mean. The reason those hospitals are leveraged is because of the wait list at the state hospital. Not necessarily because the judge or an order said this person is not going to the state hospital, they're going to WBI, for example. The vast majority of Title 25s, they're essentially taken to a designated hospital while awaiting admission to the state hospital. The reason I brought up the facilities construction project earlier, this is a nice segue, is because I'm really optimistic that when we move into that new facility, and especially, you know, next in 2021, when we bring the Life Resource Center online, this is all to increase capacity for the number of beds that we have at the state hospital, both in terms of physical plant and, like I mentioned before, with the new missions of folks that will be treated at the state hospital and those who will be transferred to the and potentially served at the Life Resource Center. I'm really optimistic that we're going to be able to improve not only the wait time, the wait list for the civil side of the state hospital, if not altogether eliminate it. I don't want to overpromise and underdeliver, but I do think that's a possibility. Then we should see more availability for communities, for courts, and folks like Paul to be able to get into the state hospital quicker. So that's essentially how that commitment process works. But when folks are committed to after a 110 hearing to the state hospital, our admissions folks at the state hospital do coordinate as much as possible with those designated hospitals to try to find a placement option, especially if those hospitals are full. And the last thing that I'll mention, Mr. Chairman, to Paul's point, he made a great point, is that we do have some priorities for the wait list of the state hospital. For example, when folks are in detention centers under a civil commitment, and that we don't want that to happen. I don't think anybody in the legislature wants that to happen, but in emergency circumstances and because of resource constraints, it does happen. And we prioritize folks who are in detention centers and not receiving active treatment. We prioritize folks who might be in emergency rooms not receiving active treatment. But again, going back to our conversation before, we can prioritize everybody, but when the volume is as high as it was, say, 4 years ago, that's what really created that downward pressure on the communities to not be able to find resources. And we have made good progress on that. And I'm, again, optimistic that with the new facilities coming online, we'll continue to go in that direction. The final thing, Mr. Chairman, I do want to echo a comment that Paul mentioned, because he and Representative Barlow and several of you who were either part of or related to that Title 25 task force, it was a big discussion on gatekeeping of, does a designated gatekeeper have bed management authority, either at the state hospital or at another designated hospital? And ultimately, we didn't as a state go in that direction, but Paul's not wrong to bring it up that when you say, if we were to say community mental health center or any other provider, you're responsible either financially or based on outcomes for a patient, an individual going through Title 25. The providers are right to say, well, I need some admission discharge authority, and states have experimented with that, but it's a much larger conversation, and I think brings me back to my broken record spiel, which is really, if we want to move in that direction, then we have to have a larger conversation about the true mission and the true role of our community mental health system, because it's just, and frankly, not to be overly blunt, Mr. Chairman, but as we prepare this next round of budget reductions, then I don't see a way to increase, the authority or the role of a community mental health center without turning something off, because we are not going to be in a position in the foreseeable future to be adding funding to a system. It is really a tough conversation about limiting what that role is, or targeting and prioritizing it. So apologize for again sounding like a broken record, but it's very real when it comes to this Title 25 task.
Okay, thank you. Committee, any other questions for Mr. Demple? Andy, I think you're up.
Thank you, Mr. Chairman. So hopefully this will be pretty short and sweet. I just have one slide to show you guys, and then I want to add a little bit more context to a couple of the items you already discussed regarding gatekeeping. So just a real simple what it is for a community mental health center and what it's not. As is kind of been alluded to, the community mental health centers certainly are the middle people in this discussion in terms of the fact that they don't have a lot of authority. They can do assessments, they can provide recommendations and opinions, but ultimately the county attorneys and the judicial system really make a lot of those decisions, not the community mental health centers. So a couple of things. So less than half of our community mental health centers are designated gatekeepers. And I think, as Mr. Kiefer mentioned earlier, there was only 4 of them that were actually accessing funding for that directly through those previous grant programs. However, I want to point out that if you ask the directors of community mental health centers, they will tell you they all function as unofficial gatekeepers in their counties. It's an expected service from the local communities, whether it's with the hospital, the county attorneys, the county commission. It's expected that they'll be there and provide that 24/7 on-call response when somebody shows up at the hospital. What we like about gatekeeping is it's successful in diverting clients into community-based services, which is, again, the crux of what community mental health centers do. What we don't like right now is that it's not consistent across the counties, which has already been mentioned. It really varies quite a bit in terms of what the process is for the county attorney. Hospitals have different policies on how they want to handle that and when to call community mental health centers and how to involve them in the process. And then you guys touched a little bit on reimbursement. So I would say reimbursement is split 3 ways. A select few have an agreement with the hospital to receive some kind of payment for the services when they're called to the hospital to do a Title 25 assessment. or engage in gatekeeping or diversion services, like we like to call them. A few, again, a small few have agreements with their counties directly, their county commissions, to receive some kind of compensation for that. Usually it's in the form of, I believe, I'll make the example of Teton County. It's wrapped up in a kind of a bigger service contract that they provide directly with the community mental health centers and the county commission. However, the majority of them don't receive right now reimbursement for those services. And so that has, it's an expectation, but it's not something that they're usually paid to do. So I want to kind of go back to a previous conversation and say that the changes that Mr. Kiefer and Matt described in terms of the contract and that Stefan described coming up, WAMSAC, your community mental health centers are very supportive of those changes in terms of making that reimbursement available through the contracts. I have not had any communication with any of my centers that said they don't want to be part of that in their contracts. I think you would hear directly from some of them that it's tough being the middle person in those conversations in terms of making that all work. And I can't stress enough, it is absolutely based on local relationships with the hospital, with the county attorney, with all the players that are involved. And there's some work to do there. And I want to clarify, Mr. Chairman, when you asked me if things were going well, I apologize if my comments were not clear. But what I thought was going well is the communication between the different centers when they need to move patients around to different types of services and beds. There is still a lot of room for improvement in this gatekeeper or Title 25 process when it comes to the community mental health centers. There's a lot of work to do. And in fact, in Judiciary Committee, we are supposed to be going back along with the county attorneys in August with some discussion and maybe recommended changes to address some of these issues. And so we do have a work group working on that right now, but there's definitely room for improvement in that particular part of the process. To speak to a couple of specific things, through you, Mr. Chairman, Representative Wilson, on the Y-High health record program. So Y-High came and met with all the center directors late last fall and introduced the program to them, made them aware that they could register. They have that information. For us right now, it's not a great tool. It's not terrible, but it does not include any mental health or substance abuse records. So it would be medical, they could view medical information only. There are considerable HIPAA requirements that have not, that system does not meet yet. I had a conversation directly a couple of weeks ago with the state staff that was involved in that, and they said they are watching to see how Colorado does that and integrates mental health and substance abuse records into that electronic system before they recommend any leaps for us. In general, we would love to see some type of a universal system where we could provide more on-demand information. It absolutely would improve care, improve the time it takes to do things, to just be able to access those records, and especially for clients that move between counties or move between different centers. Right now, it's kind of old-fashioned. It's pick up the phone or have somebody send those records over, or that provider conversation. So we can definitely improve in that. We're supportive of the project, and we hope that it can move forward and provide some better access to us in the future, but a couple of hurdles to go there. I also wanted to just touch on directed outpatient commitment as it relates to the community mental health centers. So again, not to beat this drum to death, but directed outpatient commitment aligns with the community mental health centers priorities. However, we've had some discussions about some issues potentially, and we're broaching those right now with the county attorneys in terms of enforceability. If somebody's on a directed outpatient commitment, how do you actually get them through the process to get that revoked if it's not a good fit? And how does that all work? Again, this is kind of a little bit of a learning curve, but in general, that's something that WAMSAC and your community mental health centers are very supportive. And I think what I'll just end with on gatekeeping is that Title 25 is a work in progress. There's been some changes made. We want to continue to be able to provide those services. But again, as I noted, I think on the slide, in terms of budget cuts and how this all rolls down, there are concerns about what that will do to services and programs. And certainly gatekeeping and how the community mental health centers can respond due to budget cuts is a concern. Keeping 24/7 on-call staff is an expense, especially for the small and medium-sized centers that are out in the rural areas. We're trying to explore all the possibilities. Can you do an assessment via telehealth? What does that look like? Can we improve a policy with the hospital to try to provide more coverage? All of those things are going to come up for discussion very, very soon. So we support the program. We want to keep it going. We support the changes in the contract, but I just want to caution everybody, again, we do not know what the budget cuts will look like. And we may be back with, some different information in a month or two. So with that, I would stop and stand for any questions, Mr. Chairman.
Okay, committee, any questions for Ms. Somerville? Andy, I would just like to go back to, you started your comments on this portion as you referred to the slide, and you talked about being on 24/7, and you says, however, all community mental health community health centers understand that they're on call 24 hours a day. When the call comes, that they need to be up there. Are you sure that all the community mental health centers understand that?
Mr. Chairman, as it's been explained to me, yes, I certainly hope so. That is a tenet service of the community mental health centers.
I would just suggest that in some of the conversations that I've been involved in around the state over the last summer, that seems to be some point of contention between the community mental health centers and for emergency rooms, as they're trying to get an evaluation on whether somebody ought to be committed and move forward in the judicial system, and sometimes are less than willing to come up and meet that perhaps in the way that you would lead me to believe in your comments. And so and it's been somewhat, and so I'm just trying to understand if that is indeed what the community mental health centers expect their people to do, particularly those that are on call, or not. So Representative Barlow, and then Paul, I seen your hand.
Thank you, Mr. Chairman. So I think we're digressing a little bit away from gatekeeper to now an examiner, and someone who actually does an assessment of somebody after they've been detained. So I want to make sure that we're all understand there's a little bit of a divergence here into what a role, a statutory role of someone, what their duty they're performing. So I guess my question, and I'm not suggesting Representative Larson is incorrect, Chairman Larson is incorrect, that there's differences in how people, but are we talking about the gatekeeper function? Are we talking about an examiner function? Because I think those are also dealt with through contract, maybe differently too. And maybe Stefan could get back on and talk about the examiner issue, because that is a separate, in my view, that is a separate issue from the gatekeeping component. Thank you.
And Representative Barlow, indeed, I would agree with that, and I would just suggest that that was kind of the direction I understood that, is that, come whatever time of day comes, that we're there to meet the needs, so I think that is separate from the gatekeeping, but it is part of the examiner portion of that. And is that defined differently in each mental health center's contract, or is that pretty much standard across the state? Paul, maybe you can help us with that.
Mr. Chairman, I think I can, and I'll speak only about Sheridan County. we are, and I'll give you some history on it. We are a community mental health center that does not ultimately do the involuntary, the Title 25 evaluation in the ER. We do go up, we do provide services, and we do follow-up services. How that came about was when I first got here, up to Sheridan, that is, the drain and demand on the community mental health center was we weren't able to see. We'd have people over there all the time for all kinds of things, and so it was basically a blank check to at their beck and call, come over and do stuff, and we wanted to help. But I had talked with the folks involved and said, in order to continue that and not cancel services, not cancel groups, I need to find another way to help fund this and support funding it. So we had talked about the possibility that the hospital could kick in and help with some of the funding. And at the end of the day, they decided to hire their own social workers to actually do that. Although I think the examiner probably is mostly the doctors doing it. So at the end of the day, that's the services and expectations became, we're giving you money, so do all of these things, and it just became untenable. And so that was really a way to try to do that. And again, at the end of the day, the hospital opted to go a different direction. Now in counties, in terms of county money, I don't really have in any 4 counties saying we're going to give you this amount of money to do this. Maybe there are some counties that do that. But I can tell you in Sheridan County, and it's going to be a lot less than that this year, I get a grand total of $25,000. That's it. So at the end of the day, trying to figure out how to make this thing work, I can say if and again, we're the community mental health center. We're your mental health center. If you all came back and said, we want every mental health center to be the person in the ER and 24/7 regardless, then I got to cut somewhere, because I'll have to designate people. That's all they're going to be doing because of the canceling of all kinds of services. I don't know what the right answer is. Coming from Casper, they didn't want us in the ER for various reasons. Mr. Chairman, I think I hope that gets to your thing. Are all the mental health centers, because when people say crisis services, that's a broad thing. And I hope I didn't overstep by assuming that you were thinking, are they going to the hospitals and doing the evaluations for the hospitals?
Well, thank you. And I appreciate that explanation. I think what it really tells me is, again, there's just inconsistencies on how that is approached across the state, because I tell you, in this part of the world, that the hospitals say that's not our job. We didn't bring them here. We can evaluate if they need to be hospitalized, but it's not our job to determine if they need to be committed or if there's psychiatric issues. And so that's been a work in progress, and it hasn't been without some struggle. But I think, I don't know, I think that maybe needs to be part of the conversation in delineating whose job that is in some way or manner, because it would sure do away with a lot of misunderstanding and interpretation of who's on first and who's on third. Okay, thank you. Any other questions for Ms. Somerville? Okay, Elizabeth, do we have anybody in the waiting room?
Chairman Larson, we do, and I believe it is Cheryl.
Okay, Cheryl, we're glad to have you back, and I believe you're still with us by phone. So from Carbon County, can you hear us?
Oh, thank you, Mr. Chair, members of the committee. Cheryl Folland again. I can tell you that Andy is absolutely 100% correct that there is a lot to do on the Title 25 process. Mr. Chair, your comments about inconsistencies across the counties is absolutely correct. I can speak to the process here in Carbon County where we had a county employee who was responsible for the 24-hour services for the gatekeeping and process. Unfortunately, he decided to retire last year. And we have not, as a community, been able to hire someone in his role because of what Paul has said is absolutely correct as well. One person doing 24/7 services is unattainable. We have lots of gaps. Fortunately, we have a good working relationship in our county. As I had relayed earlier, there's only 8 of us that are licensed in the entire county that participate in the process. 2 individuals from the Community Mental Health Center. However, only one provides those 24-hour services as the gatekeeper. And if she is tied up in groups or her daily work, then we have a huge gap. 9 times out of 10, what happens is that the emergency room physician will contact whoever the provider is, if they have a therapist or counselor. We are a small enough community that we get those phone calls and they will advise that, hey, one of your clients is in here. How soon can you get over to evaluate? So we do have that good working relationship. I would love nothing more than to have someone from the centers and that funding have someone 24/7, but it just is. It's not possible in our current situation. I can tell you that when I do go, if my client is on Medicaid, there are some reimbursements that I get, but for the most part, I spend 8 hours attempting to get someone to WBI or to Denver Children's. I don't even contact the state hospital. It's just not an option for us. So we do divert from that process. By virtue, they never take them or have an open bed. So we stand at a loss with that. On an average of getting someone into WBI, it depends on their bed space. So what Paul and Andy have talked about, and Deputy Director Johansson, is absolutely correct. And it is across the state. The challenges are numerous. And because the counties have their own different processes for this emergency detention Title 25 process, that gets confusing as well. Then if, I'm sorry, I was looking at my notes to see if I could answer some questions that had been put forward. One of the challenges that I have as a private practice person, I'm not credentialed with our local hospital, so I have no admitting privileges whatsoever. Therefore, I don't have access to any mental health records. So, for example, if I have a client that is evaluated, I'm on the phone with WBI, they say, send us your information. I literally have to leave the hospital, come to my office, print off all of my records, go back to the hospital, fax my information along with the emergency room's information, and then wait another 3 or 4 hours to see if they will accept my client or not for placement. And unfortunately, that's not just WBI, it's any of the other designated hospitals. So if you're not within that realm of credentialed by your local hospital, accessing or part of the community mental health centers, we have no access to other records whatsoever. So that is a challenge as well. And we do a disservice, frankly, to our clients and to our community members who are in crisis. With that information, I stand for questions.
Thank you, Cheryl. Members of the committee, any questions for Ms. Foglin? Okay, thank you. Stefan, was there anything you wanted to respond to with any of the public comment?
Mr. Chairman, thank you for the opportunity. To Ms. Follin, one of Ms. Follin's comments, and she's not entirely wrong about the challenges we've had at the state hospital, like I mentioned before, with wait lists and with wait times. I would still encourage anybody in the communities, especially in the Title 25 process with your adult clients, that when that process reaches its culmination through an involuntary hospitalization order, our state hospital does work diligently to either admit the patient or try to help find a placement for the patient. But I just want to make it clear that we essentially wait for our legal authority until someone is in our custody at the state hospital to do that admissions coordinating, to do that work. To Ms. Follin's comments about working with adolescents or children with psychiatric issues and trying to send them to WBI or Denver Children's Hospital, what have you, I will reiterate to the committee that we do not take kids at the state hospital currently. The policy question is, should the state hospital or should a state facility be a safety net for children in psychiatric distress, or kind of that safety net for psychiatric adolescent populations? And that's a broader question, but I'll be blunt with the committee that the state hospital, we are not staffed for it. We are not resourced for it to have an adolescent or a child unit at the state hospital. Senator Schuler at our last Joint Labor Committee brought that up, that in previous years, the state hospital has had an adolescent unit. It's been a number of years, and Senator, I don't know, even decades before my time, that we did admit children to that facility. But the reality and the truth is we don't right now. That hospital is set up in its current scheme for Title 25 civil commitments and Title VII forensic evaluations on an inpatient basis. We would have to be very targeted and strategic as a state in setting up a facility for children on a psychiatric basis. And I think when it comes to civil commitment, the very definitions in the civil commitment statutes of danger to self or others is one, inability to care for oneself. These sort of civil proceedings, and again, just from my perspective, assume an adult client when you're talking about a civil commitment. Now, Title 25 is used on occasion by courts, and I'm not saying it's inappropriate, but used in emergency situations or what have you, when there's no other option for children, and the court uses its authority to essentially force a placement, or at least force that discussion of a placement. So, Mr. Chairman, those were just my few remarks to Ms. Follin's testimony, and I think there's always opportunity for improvement. But again, would just reiterate that when it comes to some of the perception that's out there, especially from years past, that it's not even worth calling the state hospital or having the community look to that as a resource. Times have changed, and I think especially in the past year and going forward with the new facility, we anticipate a lot of progress there. And from previous eras, before my time, I heard one county attorney put it as the rule of 45. Either there's 45 people on the wait list, or it's at least 45 days to get into the state hospital. And that's certainly not the case anymore. But there are still significant challenges with volume and with wait times. I'm not candy coating that at all, but I think we're making progress. Thank you, Mr. Chairman.
So committee, as we move into this last section, and I'm going to turn this back over to Stephen, I think the intent when I developed this agenda was to look about considering our the efforts that the executive branch is going to make on reducing budgets and how we determine how we reimburse community mental health centers. We started out today talking about community mental health centers. We talked about Department of Education and Department of Family Services, and we've kind of narrowed that down to where we're now just really focused on the community mental health centers, and incorporated in that is the gatekeeping statutes. And I think that we've heard repeatedly from our from the Department of Health as well as from the public comments that as we look about how we do this, that it's probably going to be it is our responsibility to then determine what populations are served and what we expect our community mental health centers to do. And so I think what I would like to do was kind of wind up this meeting perhaps by asking Stephen to come back and just and just ask him if he could have his staff ask him if they have started working on identifying what they figure the priority populations would be. And then I would also like to also give that or make that same request back to Paul and to Andy to see if there are community mental health providers who says, okay, if we're going to be reducing our budget, who is it we should be serving and what is the role? And then I think committee members, what I think we should do then is Stephen kind of winds us down here is gather our thoughts and kind of put these same questions and submit them, and we'll share them. I'll have John and Elizabeth compile all the questions, and we'll share them amongst the committee. Chairman Kinski and I will take time and rely upon Representative Barlow and Chairman Wilson and kind of figure out how we approach the next meeting and what we focus on. We've talked about waivers. How do we incorporate more federal dollars and relieve the burden on general funds? I think these are all fair questions, but I don't know that we need to start plowing that ground today. I just think that we kind of understand where we're at and need to identify the direction we're going. So, Stephen, have you guys
Mr. Chairman,
how that ought to proceed?
Mr. Chairman,
please, Chairman.
If I may, I just curious. Evidently, we won't get to it today, as I see it heading for the home gate. But a third of our charge relates to Department of Corrections vis-a-vis mental health and substance abuse. And so if we're not going to touch on that in this meeting, hopefully we would spend a fair amount of time on it at the next. And I'm not sure that we can get to the solution stage without having explored that. And perhaps the mental health or the members of the task force, Representative Barlow, whatever it was, or the Labor and Health Committee have already plowed that ground. I know it. We dwelt a lot on Judiciary Committee about how we deal with patients or convicts being discharged or people on parole or probation in their mental health services. And it sounds to me like that's intricately caught up with the community mental health centers, but we really haven't spent a whole lot of time on that today. So, and that's okay as long as we do it at a future date. But before we shut her down, I have some questions on that, some research topics for Stephen and the department that would form the groundwork for follow-up at a subsequent meeting talking about Department of Corrections and Community Mental Health Services. Thank you, Mr. Chairman.
I think that your point's well taken, and I think we have part of the agenda set. Well done. So Stefan, can you?
Thank you, Mr. Chairman. And yes, Mr. Chairman and members of the committee. So to answer your question, Representative Larson, we have started that work. It was, I believe, before or during the legislative session and before the COVID-19 outbreak, which has consumed a lot of our time the past couple of months. But we did start the work with our internal staff on coming up with a process and mapping out conceptually what these categories of populations would look like. Again, not to develop the vehicles to make improvements, whether that's policy vehicles, waivers, financial, what have you, but to start kind of blank slate and look at if we were creating a system, how would we categorize populations in need? Then the second step would be to quantify in a very general sense, kind of like we did today, who are those populations, where are they, what are the coverage funding sources, et cetera. And we can do that on a narrower basis. As I mentioned this morning, Chairman Wilson and Chairman Scott did from Joint Labor task the Department of Health and the Department of Family Services to do that on a more targeted basis with our adolescent and child population. And we'll be starting that work with the Department of Family Services very soon. And I think that dovetails nicely here. So the short answer to your question, Mr. Chairman, is what I think we can do that to kind of facilitate, not from the Department of Health's perspective, but facilitate the exercise for a committee like this to go through that, to do that work in population definitions and understanding, who they are, where they are, how they're served or how they're not served, to ultimately make decisions on, what the role of the state is with regards to those populations, and then questions to be answered about the vehicles to get us there. The stick in the spokes of all of this right now, in addition to this pestering virus that we're dealing with on a daily basis, is also the looming budget cuts. So the one suggestion, again, don't want to overstep, but the one suggestion I would have for this committee and this topic in general, Senator Kinski, to your point also about the Department of Corrections populations and that facet of this, is we will know more in the coming weeks, and especially as we move into July, of exactly what our budget reduction proposals will look like. The reason I bring that up is not to punt or delay the work of a committee like this, or the work that you will task us with. We will get started on that, but it could potentially change outcomes. And so if we as a Department of Health are going to reduce major areas of funding because we have to, or Senator Kinski, if the Department of Corrections has to move in the same direction based on the directives we've received, then that could be, I think, interesting context for a committee like this or others to determine what that means for reform, what that means for solutions that may or may not be possible. So I just offer that as a little bit of a suggestion from the Department of Health. And Senator Kinski, to your point, happy to take your questions now on the Department of Corrections population and what work we've done and plan to do with that agency. Don't want to speak for them since they're not here, or happy to follow up with a conference call or a meeting offline with you, sir. So whatever works best for you.
Well, I'd like to throw them at you, and I'll be fairly quick. First of all, on the Department of Corrections, I'd appreciate an overview on where these folks are getting their mental health, substance abuse counseling, either while on probation or after being discharged halfway house or to the community. My understanding is that they can be reimbursed for Medicaid if they're Medicaid eligible, except when they're incarcerated. So when they're in a transitional unit, evidently Medicaid will pay at that point. It's also my understanding that Medicaid doesn't require, when somebody's incarcerated, that they disenroll from Medicaid. You can keep them continuously enrolled. And so I'd like to find out if DOC is screening people for Medicaid, enrolling those who are eligible, keeping them enrolled, even though they're not eligible, but the minute they're discharged, then they've already got all the paperwork done. So is there a process as Mr. Demple described, everybody comes in the door is continuously being checked. Is there a process to get inmates or people charged enrolled, and then continuously checking their eligibility once they are out of incarceration? They call it the Medicaid incarceration exception. You can't, even if you're eligible, you can't bill Medicaid while incarcerated. Then after they're discharged, do we have any data on where they're getting those services? Are they going to private providers? We saw data from Mr. Dimple that 97% of those involved with substance abuse counseling are involved with the justice system. That might be the entire universe of people, but there might be people going somewhere else. Does the Department of Health have any idea on what percentage of those who are receiving treatment are they're receiving any reimbursement for? Does it go to the Department of Correction? Is somebody else billing and collecting? So I'd like to know that the total segment of that population going to community mental health after discharge, and if they're not going there, where are they getting their treatment, who's paying for it, and what apparatus are in place to try and collect that. The other one is, so now I'm off of DOC, now I'm on the girls' school and the boys' school. The girls' school is not on a prison model or whatever you call it. They are on a medical model. And the boys' school is transitioning to a medical model. And so the ask I had of, oh gosh, what's her name? The head of DFS is to see if there's any options for seeking reimbursement for all of the mental health and substance abuse counseling that's being poured into the girls' school clientele and the boys' school clientele. And that includes when they are in the facility as well as post-discharge. And then I would just, now I'm going off of DOC, the community, the idea of having a waiver. What I'm curious about is we talked about a waiver that's where the provider is the community mental health center. They're being paid on priority populations, including DOC. You know, I have that as around a $24–25 million savings because half the cost we're paying now out of tobacco fund and general fund could go to Medicaid on that kind of model. And then is there the potential to pick up some additional savings on monies we may be spending out of our own pockets that could be foisted off onto the Medicaid system out of the DOC side? And so that exhausts those questions. And then the other is, you guys are making your plans. The governor's direction was clear. He said, look at wiping out whole programs instead of crippling programs by just cutting them all across the board. So I would like a list, and I think you've given it to me previously on approach, of all programs we are not required by the feds to implement and adopt. One is the SCHIP program. It's grown way beyond what it was supposed to. We match dollar for dollar with the feds. The feds are reducing their commitment to that program. We don't have to adopt it. Once adopted, we're not forbidden from repealing it. I know that sounds terrible. Kids 150 to 200% of poverty level, but we're in a pretty tough spot. So I'd just like a listing of all the programs we're not required to adopt, or having adopted them, we're not required to keep. Thank you, Mr. Chairman.
Thank you.
And Mr. Chairman and Senator Kinski took notes on that list of items. Much of it we have. Some of it could use some updating. So we'll certainly follow up with you and with this committee on some of these items. As it relates to the budget reductions, I will just mention the entire Medicaid program is optional. We'd be the first state to withdraw from Medicaid. But the reason I bring that up is, Senator, the 91% of the Department of Health's budget is really in 5 areas, and that's Medicaid, which includes waivers, mental health, substance abuse, developmental preschools, state hospital, and life resource center. So as we've gone through before, with many of you and with appropriations, it's a tough order to take the kind of money that we're talking about out, because we have to hit those 5 areas that really just represent the bulk of our budget. And that's all money that goes out to communities, that goes out to providers, with the exception of our support for the staff at those two facilities. That's really our overhead or administrative cost in the department. Relatively speaking, I mean, again, 91% of our budget of our general fund budget in those 5 areas. So certainly going to be tough times ahead. We will get through it. We've all been here before, and I'm confident we'll come out on the other side. But Senator Kinski will get started on either updating or preparing the information that you requested. Representative Larson, I hope I answered your questions in closing. I just want to say again, this is a policy area and a topic I never 7 years ago thought I'd be into, but appreciate the committee's time, and it's an area that's near and dear to a lot of our hearts, and I think we can make some progress. So thank you for the opportunity to testify today.
Thank you. We'll go to Representative Barlow and then to Representative Wilson.
Thank you, Mr. Chairman. So my query is regarding the timeline. The next biennium starts in 14 days. And my understanding is new contracts for community mental health centers start in 15 days. So if we are going to reduce services or impact or looking at budget issues with this, what is, I guess, actively going to be in those contracts that are different than what is in this year's contracts? Whether they're 1 year or 2 year contracts is irrelevant. What is July's contract going to look? How is it going to look differently than June's contract? Because if we're still going to require them to serve all comers, if we're still going to require them to, add duties such as gatekeeping, etc., it seems hard for me to get my head around the fact that you're going to say we were able to cut 20% of the budget. So unless we're willing to take away responsibilities, it seems I'm struggling with how you can say do the same responsibilities with a whole lot less or with less funding, and 2, how you know what that is in, i.e., 15 days, because that's when their contracts take effect. So I guess I'm interested. I mean, I heard the comment, Mr. Chairman, about we'll know more in July, we'll know more in August. Well, July 1st is when their contract starts. So either we're going to go on a month-by-month basis with these folks, creating a whole nother level of challenge and uncertainty, and not go by a year or 2 year contract, or something else is going on. So I guess I personally, I think for myself and for our community health folks, would like some sense of what the department is anticipating for how this, I don't know if it's a transition or a cliff, but how this is going to unfold. Thank you, Mr. Chairman.
So Stefan, I think that's a point well placed. And so as you guys have been considering that, how does that look?
Yeah, Mr. Chairman and Representative Barlow, it's a great question. And the simple answer is the contracts will be executed before the budget cuts are implemented. That's just a timing issue with when the direction to cut the budget has been given. So this is very similar back in 2016 for the 2017-2018 biennium, when we took about $100 million out of the general fund budget as well. Those weren't all finalized until after the biennium had started. So essentially what you do, the more you go on through July, through August, what have you, and it's the same across a lot of our service areas, not just behavioral health, you essentially, now you have, instead of 24 months of budget, you have 23 months to get that number out, and then 22 months. So we will be through areas that do receive reductions, those contracts will be amended on a going forward basis to account for those reductions. And that's when, whether it's entire program eliminations to Senator Kinski's point, or just reduction in reimbursement rates, or reduction in certain elements of programs, that's being worked through literally right now this week, and we'll have that discussion with the governor's office this month. But what I want to be clear on, Representative Barlow, is it's not, again, it's a timing issue, but it's not full implementation of the reductions by July 1st, because that would be impossible with the contracts, hundreds of Department of Health contracts that are ongoing for the next fiscal year.
Follow up, Representative Barlow. And so the question that our providers have to be asking is, how do we prepare for this?
And Mr. Chairman, we are in communication with all of our providers. It's certainly not perfect because we don't ourselves know the exact landscape. I think we anticipate another CREG report, an emergency CREG report coming in July, which will inform, you know, either further cuts beyond the initial round or some other scenario. But we are, whether it's in Medicaid or whether it's in behavioral health, aging, public health, we're in communication on anticipating changes and anticipating reductions right now. The exact, you know, the exact dollar amount and the letter of those reductions has not been finalized yet.
Thank you. Representative Wilson.
Thank you, Mr. Chairman. Two things to follow on from Senator Kinski's discussion. The first is, as the Labor Committee members know, CSG spent 2 years working on the topic of the substance abuse programming available to people coming out of the Department of Corrections custody. And that was the genesis of last year's House Bill 31. So we have all that report that was given to the Labor Committee last year, that it was a survey of the entire state and where the services were provided, everything. So I will share that with all the members of this subcommittee. And then the second thing, just to not take away from whatever wonderful work Stefan will do for us, but just a reminder that because we are not a Medicaid expansion state, the vast majority of people in Department of Corrections custody, ages 19 to 64, hardly any one of those people is Medicaid eligible. So while there might be a few people who would be eligible for Medicaid coverage, unless they are disabled or have end-stage renal disease or something like that, they are not going to be a Medicaid enrollee, other than if we do some sort of Medicaid mental health waiver. But under our current Medicaid program, virtually none of them would qualify for that. That's all I have, Mr. Chairman.
Thank you. Questions, committee? Stefan, please.
Mr. Chairman, just if I may, to Representative Wilson's comments and Senator Kinski's questions earlier, that work with Council of State Governments over the past 2 years, we actually built their model for, it's called a survival model, to look at the crosswalk between Department of Corrections clients and community mental health and substance abuse clients, and what that might look like if we were to able to reduce recidivism based on targeting kind of your higher acuity. So Representative Wilson, appreciate if you share that information with this committee, but that's something that we can certainly present on in greater detail on the corrections issue to all of you, since we worked with CSG and kind of partnered with them to build that data analysis and that model.
Mr. Chairman.
Please, Senator Kinski.
And Sue, thank you for that. Is there, without doing a full Obamacare Medicaid expansion, is there a possibility of a limited waiver expansion for mental health that would capture that inmate population that currently we're bearing the cost out of our own funds?
Mr. Chairman.
Please.
Stefan actually would probably answer this better than I. We have been looking or considering the possibility for a couple of years in a vague sort of way of a Medicaid expansion, or a mental health expansion. However, I am not sure that Medicaid would ever cover incarcerated people in any case.
No, not incarcerated. I mean, once they're released to the community. If they,
that's the waiver discussion that we were just having about, and that's one of those things where you just need to run the numbers, because again, it's not an expansion, an Obamacare expansion where we would have to only pay 10%. We would be paying the feds would pay the current FMAP, which is 50-50. But as you see, we are plainly spending a fair amount of money in that anyway, which was when way back in 2013 and 2014, when we were considering the ACA, that was where Department of Health proposed getting most of the savings from. There's been a lot of cuts since then, so that's no longer a thing, but I'm sure Department of Health, is readily able to run some numbers on that. And it's just one of those other waiver type things that we have to see. how the numbers play out. Probably Stefan has something to add on.
Well, thank you, Mr. Chairman. Thank you, Representative. The reason on judiciary is we came up with all kinds of great ideas how we could reduce the prison population and save millions upon millions of dollars, but it hinged on the right sort of support infrastructure being available in each community, and there were very few in law enforcement that were confident that that was in place. So it's the old kill two birds with one stone if we can. It sounds like you've taken a good hard look at that, and I'll look forward to seeing your report. Oh.
Any other questions, comments? Senator Bouchard, you've been awfully quiet today. What's your thoughts?
Well, thank you, Mr. Chairman. You know, we've danced around a lot of topics, but I would always like to come back to substance abuse and how much we're really spending on it and how we're trying to keep people out of the correctional system. I mean, that's because that's where a lot of the dollars and the bang for you get your bang for your buck. I just don't know how we can talk about that without, you know, there's just a bunch of fences and walls put up by different people that don't want to go in different directions. They want to keep things the same. So I just don't know what to say and how to try to approach fixing problems. So, but these are real numbers. Other states have actually taking that approach to more of a preventative approach, and even when people are incarcerated, you know, the cost of continually them going back into the prison system is a big cost to the state. So, and a lot of the people that do lobby on that issue don't work in the prisons. So, like I said, I mean, we need to touch it at some point. We need to come back and start looking at real numbers.
Okay. Representative Olson, any thoughts?
Yeah, thank you, Mr. Chairman. I do think I like a few things that Senator Kinski brought up. I wish there were a greater opportunity out there to have some type of an expansion on just mental health that tremendously interests me. I also liked what Senator Kinski said about basically an exit counseling option in our prisons and jails for people that are heading out. You know, I don't know what DOC is doing. Is it doing enough to make sure that the people who are leaving the system, going out into our community, have everything in front of them if they are eligible, and moving them onto those systems. And then I think just in general, in terms of so I'd like to really understand those two more and the opportunities that we have available there. But then in general, in terms of mental health and substance abuse treatment as it deals with our incarcerated, I think one of the programs we've yet to see the full advantages of is our Quick Dip program. I'm thankful that we were able to get that funded in the last budget. It seems to me the biggest impediment with that is what we're talking about, that there aren't necessarily, I think Senator Bouchard mentioned it, there aren't necessarily providers in our most rural areas that can offer a lot of the services in the county jails that would really make Quick Dip effective. I understand the biggest impediment is actually whether jails participate in the Quick Dip program or not. And that is hinges upon whether they're PREA compliant or not. Something we would have control over at the state level as to whether we were to mandate that to our counties or do some type of cost sharing with counties so that they were PREA compliant. If they're PREA compliant, I understand that to be the biggest impediment as to whether they even participate in Quick Dip or not. But yeah, it all comes, I think, Mr. Chairman, it all comes back to really the funding of making sure that there are providers who provide the services in the local areas, particularly in the rural areas. You know, we can stand up all day long and talk about how it's necessary and helpful for our people, particularly in our DOC, to have substance and mental health treatment up front, and to have a lot of it intensive up front, because we just know that reduces recidivism, it reduces incarceration, reduces costs overall. But if we're not going to fund that at our local level, then we're not going to see those results. So, what can this committee do in terms of that? Well, I think, the whole PREA compliance, that's probably something maybe more for judiciary, but as a whole, I think funding, making sure that the funding is available for those community providers who are offering it, particularly in the rural areas. Maybe telemedicine is another avenue to try to get some of that counseling and stuff into the rural areas. Thank you, Mr. Chairman.
Senator Giroux.
Thanks, Mr. Chairman. Boy, good discussion, and thanks everybody. I feel it's kind of funny. All my memories from my 2 years on labor health are all coming back under good Chairman Barlow, and the many meetings that we spent talking about all these discussions, Title 25 and all this coming back. On my first meeting, actually, I spent as a representative-elect. I was sitting next to Chair Wilson and talking about these very subjects. And I guess it was something, just kind of overarching thing that hit me, and going back to, once again, another committee I serve on about that CHINS program we took up in management audit. Something that Chair Wilson said, one thing it seemed like we have to do, overarching through all these things we're talking about, is we have to break down these silos. We have no way of evaluating these programs to see how well they're doing, who's doing what, and how the client's getting the service, and how much we're spending on each client, because they're not talking to each other. And we still don't have a good handle on that. And before we start just taking it a whack at cutting programs, I think we really need to commit ourselves to try to work on that goal. And I don't know, I even joked with someone, is there someone we can do a blockchain where we just assign everyone a number, so we don't know their identity, so that way so we can keep our HIPAA requirements safe and pass that information between groups so they can watch that number and how those people are getting their services. I don't know. But also, something that Representative Olson said is key, is going to be on my question too, is what role can telehealth get us to try to save these costs? And the only other thing I'd say, and I'll get in trouble for saying it, but since I have a rule, when someone says Obamacare at least twice in one meeting, I always have to respond with saying, why the hell don't we just expand Medicare and be done with it? So that's just, those are kind of my thoughts on be the center of my questions. And thank you, Mr. Chairman.
Thank you. And finally, Senator Schuler.
Thank you, Mr. Chairman. Really good discussions, a lot of really good information from everybody. I really appreciate the Department of Health, and of course, Stefan, he's always on spot with everything, and he's usually 2 steps ahead of what I'm thinking. But yeah, I think, obviously our budget concerns are that's the uppermost, I guess, priority is what do we do? I mean, I think we've got to find ways to fund our community health centers, because I think if we don't, you either pay now or you pay later. Do you want to pay that $45,000 when they go into the state pen or whatever? So I think telehealth is certainly a way. Maybe I think they're having good luck with that, and the data that I've seen says it's pretty effective, actually. Maybe it's as effective as in person. So I think that's something we need to look at. And obviously we didn't really touch on corrections, but that's going to be a big lift, I think. And I hope we continue with our the reforms we've done with justice reforms and whatnot. But I think we've covered a lot of it. But we've got to do something, I think, with funding issues. And I have a couple of ideas, but I think I'll wait till maybe the next one. I want to do a little percolating on them and maybe a little more research. I'd like to kind of see what some other states are doing with waivers and those kinds of things. So just appreciate all the good discussion today, and thanks for your leadership, Chairman and Co-Chairman.
Thank you. So today's the 16th committee, and if you could please try and have your thoughts put together and back to us by Friday. And then the chairman and I will kind of sit down with LSO and put out some dates for a follow-up meeting and start preparing an agenda. I think that we don't want to be piddling around here, because we want to try and have this stuff done for as Labor and Health and JAC meet in their committee meetings. Does that sound okay with you, Chairman Kinski?
It sounds wise, as you are always, Mr. Co-Chairman.
Yeah, okay. So with that in mind, appreciate the comments of everybody. I know that we covered a lot of ground, and really appreciate our Labor and Health people as they heard this for the umpteenth time. I know that, but it was good for us on JAC to hear it. And again, as Senator Guru pointed out, it does bring back fond memories. So with that, Elizabeth, John, is there any cleanup that we need to do before we close our committee?
Mr. Chairman, it would just be up to the committee and the chairman on whether or not a final opportunity for public comment should be offered, given we did have that final agenda topic regarding CMHC reimbursement.
Thank you. And you're absolutely correct. Do we have anybody waiting that would like, does Paul or Andrea or Cheryl, any of those three, like to make a final comment?
Chairman Larson, they are all three still in the waiting area, and I can admit Paul and Andy at the same time.
I think that'd be great. And I apologize if we looked like we was going to jump ship and leave you. We were, thank heavens for LSO. Paul, you're up when we get you there.
Okay, so sorry I was caught off guard by the delay. I'm not going to say, everything's been said. What I'm very encouraged, especially when the chairman really clarified that it's really about who do we serve, what is the mission, and we only got so many dollars. I think this discussion's been a long time coming, so I really appreciate that. The only thing I would say going forward is that we really have to make sure, as you can see by my local data, sometimes the 30,000 foot level data doesn't quite sync up. So as we're moving forward and looking at different payment or who we're going to see and all of that, that we can work in tight coordination with you, and especially tight coordination with the deputy director and his folks. We've had discussions over the last year of really, as community mental health centers, being committed to having those real discussions with the Department of Health, so we can come up with something that's not handed out, but something that we all say this is going to work. And so that would be my only thing, that in those discussions that happen. I'm sure the deputy director already has that on his radar. But other than that, I just thank you so much, and I appreciate the committee's work. That's it.
Paul, thank you for the information you provided. It was very helpful. Thank you. Andy, you're up.
Thank you, Mr. Chairman. Just to echo Paul's comments, thank you again for the time and attention to this topic. We had a plan to have these conversations, and it's gotten a little bit derailed by COVID and budget cuts, but I think that it's still good conversation. And Mr. Chairman, to your comment about, or request about whether we were thinking about what those services or populations might need to look like, I just wanted to let you know those conversations are underway right now in all of your community mental health centers. Again, just to echo Deputy Director Johansson, everything will depend on what comes out in July. And we will certainly communicate that back to this committee and work on that as things unfold. But in the meantime, we're just happy to have the conversation. So, and as always, WAMSAC is available to answer questions, or whether it's your local center or the system in general. Thank you, Mr. Chairman.
Well, thank you. But Andy, if I might, I would just like to request, and I appreciate you saying it kind of depends on what comes out in July, but if you were making recommendations as to what those priority populations would be. You know, we're wanting to include your input as we make these decisions. So that, you know, I'd really request we be a little more proactive than reactive on that. And so the same question would apply. If you've got suggestions or ideas that we could start looking at, that would be greatly appreciated.
Mr. Chairman, I will circulate that around my centers and get their feedback and get that back to you.
Thank you.
Thank you.
Okay, Cheryl, Ms. Folan, if we can get her on the phone. A little more proactive than reactive on that. And so the same question would apply if you've got suggestions. There we go. Cheryl, are you with us? I think we've got her muted. Whoop, and
Thank you, Mr. Chair, members of the committee. Thank you for the opportunity, as always, to speak to you. I know the focus tends to be on the community mental health centers, but I always like to let the committees remember that those of us that are in private practice are just as much part of the system as those with contracts and directives legislatively and statutorily. We are here to assist and provide information that tends to get lost when we look at the overall system, and especially those of us in very small areas, having practiced in Evanston, where we had to send most of our people over the border to Utah because we just don't have the resources available. And in Carbon County, where there's only 8 of us, for however hundreds of miles we exist, that have those challenges. And my colleagues and I do greatly appreciate all of you and your time and your commitment to helping and looking at how we can best serve our neighbors and the corrections population, which obviously I sit right in the middle of, being in Rollins, and the abilities of the brain trust that you guys hold is absolutely amazing, and we do want you to know that you all are greatly appreciated in the time that you give to these topics, and they are so important. And I understand that the budgets hit us all. We weren't looking for any of these challenges any more than what we had on a regular basis. And if any of us can assist, we want to be able to give some creative input and alternatives, especially in the telehealth situation. Telehealth is great for adults, not so much for kiddos, which tends to be 70% of my population. A little hard to do child therapy over telehealth. But we are looking for any ways to assist you in being successful in helping the citizens of our wonderful state. Thank you.
Thank you. Okay, do we have any, Elizabeth, John, do we have anybody else in the waiting room?
Chairman Larson, we do not.
With that, we will close this meeting. Thank you, Mr. Chairman and work group members. Look forward to seeing your information.
Thank you.
Thanks, John. Thanks, Elizabeth.